we'll have the back table basically on the side of the arthroscopy. So Rachel's going to be positioned back here as I'm ready to do my scope. I'm going to have the MRI at basically the head of the bed on the side where I'm doing my arthroscopy. And on my MRI screen, which we'll cut to in a second, I'm going to have the lesion for a coronal, a sagittal, and an axial. That'll allow me to triangulate my lesion really nicely there. And then I'm going to go ahead and have the cross side of my room. So I'm going to have my arthroscopy tower, my pump, my C-arm coming in from the opposite side of the bed, and then my x-ray at the foot of the bed. And this is going to allow me to sort of work really smoothly. At the foot of the bed, I'm looking, and I'll go ahead and just take an x-ray to get a starting point. So now I know that I'm pretty much near the joint line on the medial aspect of the knee. I have my MRI across the field for me, so I'm able to see exactly where my lesion is. And in this case, it's basically down towards the subchondral bone on my lateral as well as on my AP. So once I've got that spot, I'm going to level out here. I'm going to take an x-ray. So once I think I'm in a position that I like, what I'll do now is I'm going to have JP swing into a lateral position. Move this a hair. X-ray. And now I'm feeling pretty good about my location. One more time, x-ray, please. Good. So I know with my MRI across the field for me that I'm in the right spot. And then I'm going to run under power my pin directly into the bone. The hole will be outside the bone. I confirm my location that I like. So what I'm going to do now is I'm ready to inject. And at this point, I'm ready to inject my calcium phosphate. Can I have the first syringe, please? So I'm going to choose to start with my femur, although there's no set in stone way to do it. And I'm going to inject, and Sharif, we talked about this. When I inject and when you inject, you're looking for that tactile feedback. So I'm basically just using my thumb with 2 fingers around the plunger, and I'm loading the chamber. And using these chambers, you and I have spoken about this a couple times, the chamber itself will take 0.7 cc's before it even gets into the bone. So you shouldn't feel any resistance with the first 0.7 cc's or so of what you're injecting in there. But once you get past that, you'll start to feel a little bit of pushback, and that's what I'm feeling with a tactile feel. So as you mentioned, I'm feeling some tactile feedback. I'm going to rotate my side delivery pin 90 degrees. I'll inject a little more. So I feel pushback. Rotate 90 degrees one more time. A little more goes in freely. And again, 90 degrees more. I got good resistance there. I'm going to stop there. I don't want to force this. We don't want to overfill this lesion. I'll remove my calcium phosphate. I'll use my orange stylet to place this right down and clear the chamber. And I'm going to let that set and cure. I know that I'm pretty much set here. Let's take an x-ray. So on the x-ray, you'll oftentimes see a blush on the x-ray where the calcium phosphate sort of filled that defect. You may not always see it. Again, a lot of this is just understanding your lesion. But oftentimes you'll see that little blush and discoloration in the bone. And I think it's nice confirmation for us. But I'll let this set for about 5 to 7 minutes. Then I'll pull the pins. I'll put a steri strip over both poke holes, and I'll close my portals, and I'm done with the case.